Thank you, sir. So today I'll be talking about how to manage endophthalmitis, where the vision is better than PL, to be frank, and I'll be focusing more on the need of intravitreal and to avoid core vitrectomy. So my points in the favor would be, just to explain, postoperative endoff is defined as infection within 6 weeks of any invasive procedure of the eye. Before I proceed with the talk, I would like to present some cases. This is a case 1 presented with finger counting 2-meter vision. As you can see, with moderate vitritis. After 3 weeks and 3 intravitreal antibiotic injections, the vision improved by 6/36. This is the second case in which the patient presented with vision PL plus dense vitreous pupillary membrane around 1 millimeter hypopyon. The patient received 5 serial intravitreal antibiotic injections followed by vitrectomy later on. After 1 month, the vision improved to 6/60 and the vitritis nearly resolved. This is the case 3, vision hand movements close to face. 2 intravitreal injections were given. After 2 months, the vision improved to 6/18 and after 3 months, the vision improved to 6/9. This is the fourth case, patient presented with vision 6/60, received 3 serial intravitreal antibiotic injections. After 2 weeks, patient's vision improved to 6/12. So the rationale of showing you these 4 cases is that, as you can see, except the second case, all the remaining 3 cases had vision somewhere in the range of hand movement to 6/60 or something. And we managed to successfully treat these patients only with intravitreal antibiotics. Depending on the severity, the number varied. Only in the case where the vision was as bad as PL+, that was the only case where the intravitreal injections were followed by vitrectomy later on. So the protocol visually which we followed is, when the patient presents to us, we take an AC tap, and if the AC is very flat and all, then we prefer to take a vitreous biopsy. The tap is sent for culture, KOH mount and gram staining. At that point, when the AC tap is taken, we give an intravitreal antibiotic of vancomycin and ceftazidime, as is the norm. Where we suspect fungal infection, we give only intravitreal voriconazole. Except in where we're suspecting a fungal cause, we also give intravitreal steroids along with the antibiotics. We have a protocol of giving systemic antibiotics also to the patient. We preferably want to admit the patient for 5 days, where we give intravenous ceftazidime and gentamicin injections, which is later followed by oral course of steroids by 1 milligram per kilogram body weight after the hypopyon and the vitritis has resolved to a great extent. So our protocol, in which we refer early vitrectomy in vision where it is vision is better than PL+. Why so? The points in our protocol favors are: first, when the patient presents to you with an acute endoff, the view of the media is hazy due to corneal edema and anterior chamber exudates. Now, doing a core vitrectomy in such an eye is essentially a blind procedure. So there are high chances of instrument touch both to the iris as well as to the retina behind. The infected retina is always very friable, and as it is ischemic, so more chances of iatrogenic breaks. Inflamed eye, so more chances of intraoperative and postoperative hypotony, which can cause suprachoroidal hemorrhages, etc. It's a painful procedure owing to severe inflammation, and it also causes psychological trauma to the patient as it involves a second surgery soon after. So just to brush over, our approach is, if the vision is more than or equal to hand movement, we just give serial intravitreal injections on alternate days till hypopyon resolves, which is later followed by a course of systemic steroids, which is tapered gradually. If the vision is PL+, we initially give 2 intravitreal antibiotics alternately, followed by systemic steroids and core vitrectomy if needed. So just to give you a short statistics, in our institute, over a period of 5 years, we had 57 cases of endoff, in which 41 got cured only with intravits, 10 required intravits followed by vitrectomy, and only 6 cases required vitrectomy, which was followed by intravits. The Moorfield study, which was conducted between 2013 to 18, also showed that 33 patients which underwent core vitrectomy, 8 developed RDs, 5 had iatrogenic breaks, 5 required resurgery with tamponade, 3 had choroidal effusions, while 1 each had macular hole, 1 had to be eviscerated, and 1 had to be enucleated. So in the Moorfield study, all 27 exogenous endophthalmic relatives received preoperative intravitreal antibiotics, and the mean duration between injection and surgery was 8 days. So there is a no hurry core vitrectomy approach we follow, the benefits being organization and consolidation of the vitreous exudates. The evolution of PVD subsequently helps in the core vit, less pain to the patient as the eye inflammation subsides a bit following serial intravitreal antibiotic injections. So my take on this, in less severe cases of endophthalmitis can be successfully managed by intravitreal and systemic antibiotics and steroids. Core vitrectomy should be reserved only for severe cases.